We are getting more people into the room. We will ask you to please look at the slides. You'll see who our presenters are, and pretty soon we'll have a slide up on how to get continuing education. When that slide goes up, I encourage you to take a picture of it so that you'll remember what it says. We'll also put that in the chat as well. So you'll have lots of opportunity to see the information. Dr. Jill Hamilton-Reeves, would you like me to get started? I think we can.
Yeah, go for it.
Excellent. So hello, everyone, and welcome to the 7th program in the Kansas and Missouri Cancer Research Highlights. It's hosted by the Masonic Cancer Alliance, located at the University of Kansas Cancer Center. I'm Hope Crable, the Executive Director of the Masonic Cancer Alliance, and I'm really delighted to introduce our moderator for this program, Dr. Jill Hamilton-Reeves. So Dr. Hamilton-Reeves is a professor of the Department of Urology at the University of Kansas Medical Center and co-director of the Nutrition Shared Resource at the University of Kansas Cancer Center. That's a lot of universities in Kansas, Jill. So Dr. Hamilton-Reeves serves as the lead researcher for PIVOT, which is our patient research advocacy program. It stands for Patient and Investigators Voices Organizing Together. This group helps improve research at KU Cancer Center by including voices of patients and survivors and co-survivors of cancer to inform all aspects of research. Jill's own nationally funded research program works with urologists and medical oncologists to foster the discovery of better diet and exercise approaches to benefit patients with cancer. So Jill, thank you for moderating this program. We are really appreciative of it. And a reminder before I hand it over to you, everyone, please look at this participant information slide, and you will get to chat questions in the chat, but please do not provide any patient level information. So Jill, off to you.
Great, thanks, Hope. Good evening, everybody. As Hope said, I'm Jill Hamilton-Reeves, and I'm excited to be serving as the moderator today. On behalf of the MCA and KU Cancer Center staff, we really appreciate you taking some time out of your day to be here with us. Before we get started, we do have some housekeeping items. Hope already touched on some of these. First, as a reminder, the Zoom session will be recorded. You probably already saw that prompt in the dialog box come up. Second, if you would like to ask a question, you can type your question in the chat box. And we have dedicated times during the program where a staff member will be posing your questions to our presenters. And then finally, be sure that you're aware that the questions and comments do not contain patient information. All right. I think we can go ahead and get started. Our first presenter is Dr. Gary Doolittle. Dr. Doolittle is the Capital Federal Masonic Professor of Medicine in the Division of Medical Oncology at the University of Kansas Medical Center. He's the Medical Director of the Masonic Cancer Alliance and also Vice Chair of Education in the Department of Internal Medicine at KU Med. And lastly, he's the Assistant Dean for the Office of Medical Education. Dr. Doolittle, thank you so much for joining us this evening. Welcome.
My pleasure. Thanks, Dr. Hamilton-Reeves. It's really a pleasure to be here this evening. We have discussions back and forth within the Masonic Cancer Alliance offices and with staff about topics for these sessions. And this one is particularly interesting, I think, the whole emergence of cellular therapeutics in the care of cancer patients. And it's just what's coming to the clinic is just nothing short of amazing. So we wanted to take some time this evening to go through some of this. And I'm going to kind of set the stage a little bit about how these different approaches work. And then Drs. Neupane and Al-Rajabi are going to come in with disease-specific applications. I am a melanoma doctor, and with that, you will find all of my examples are melanoma related. So I'm, that's forewarned is forearmed. You know that you're going to hear a little bit about melanoma in the next 5 to 10 minutes. Let's go ahead and share the screen, and I'm going to count on Dr. Hamilton Reeves to tell me if we're doing okay.
The screen looks great so far.
Okay, good. So always, just as a doctor in the clinic, but in a session like this, it's all about breaking down the information so that it's clear to the audience. And in my case, so that it's clear to patients. And there's so much in the lay literature right now. This past week, there was an article published in the New England Journal that actually got quite a bit of press, and I've had quite a few questions about it. And it has to do with harnessing cells of the immune system to fight cancer. Most of us are quite aware that the immune system fights infection, it clears cells that are damaged in the body, and it also goes after cancer cells. And we've known this really for well over a century, this strong interplay of the immune response with cancer. And that sometimes the immune system can win and sometimes the cancer wins. So how does this all break down? What branch, if you will, of the immune system, or what kinds of cells are actually involved? And many of us know that the bone marrow is essential to the immune system. It produces cells called lymphocytes. And in our case, the types of cells we use for cellular therapy are T lymphocytes. They're produced in the bone marrow, and then they migrate to a gland called the thymus. And throughout childhood, these cells continue, and we start to lose the thymus gland as we get to adulthood. The T cells being in the thymus gland actually mature into either cytotoxic T cells, memory T cells, helper, or regulatory. And what I really want to focus on today is the cytotoxic T cells, because these can attach to cancer cells and kill them. These are activated cells that migrate through the blood vessels, through the system, throughout the body, throughout other organs and tissues. And it's really important in that they can also travel across the blood-brain barrier. So the blood vessels within the brain have this protective effect that prevents toxins from entering the brain, which is a good thing, that's protective. But in the cancer world, if we have cancer cells or tumors in the brain, we want to know that our therapies can reach those. And one of the advantages of T cell therapy is that these cells can break through the blood-brain barrier and get to tumors within the central nervous system. So today we're going to talk about two different forms of cellular therapy, one called TIL cell and the other called CAR T cell. So TIL stands for tumor infiltrating lymphocytes. And again, these are immune-specific cells that have migrated throughout the bloodstream and located in the cancer itself. So if you look at the schematic on the slide, this actually represents a cancer in the body, and T cells that have migrated to this particular cancer and set up shop there, meaning they have activity against, in my case, against melanoma cells. And the idea is to take this tumor that is enriched, if you will, with T cells that can kill melanoma and remove them, remove that tumor from the body. Once you remove the tumor, you extract out these lymphocytes. You extract the tumor infiltrating lymphocytes. And then remarkably in the lab, these are grown, we say ex vivo, or they're grown outside of the body into literally millions and billions of cells. And the advantage of this, the advantage of T cells, again, they are directed towards the specific cancer that they were infiltrating, right? So you get a bunch of these T cells and then you give them back to the patient. It's not a new concept. These kinds of studies have been done since the mid-80s at the National Cancer Institute. But what's different now is we have a much greater understanding of the interplay between T cells and tumor cells. And the other thing that's happened, our technology has gotten to the point where we can grow these much more rapidly in the lab. We're looking at maybe 2 to 3 weeks of growing these cells in the lab, when it used to take 6 to 8, even longer, weeks to grow these cells. And all that time, the patient is waiting for a cancer-specific treatment. So tumor-infiltrating lymphocytes, lymphocytes that migrate to the tumor, they're specific for that particular tumor, multiplied or grown outside and then given back to the patient to get that anti-cancer response. So we flip from that then to, I beg your pardon, let me go one more slide. There we go. CAR T cell therapy. It's different. It's different, but it's still the same concept. We're using the patient's own T cells. We're harvesting them from that patient, and we're going to change them into a cell that has activity towards a specific cancer. And it's really well illustrated on this schematic. You remove the cells, you put it in a large IV, pull the cells out. There's a machine that spins the blood and pulls out the white blood cells. And within that white blood cell pool are these T cells. Those are the cells that they're really going after, and those get removed, and then they get transformed. They're actually, a specific gene is inserted into the T cell, and that gene makes a protein that goes to the cell surface of the T cell. This is called the chimeric antigen receptor, a very specific receptor that sits on the T cell, and that receptor is directed towards a specific protein on a cancer cell. Okay, so they're called CAR T cells. The CAR stands for chimeric antigen receptor. Don't want to get bogged down in the terminology. Let's just go with CAR T, right? And recognize that that particular cell has been engineered to go after a very specific protein on a cancer cell. Okay, so those T cells, same concept. They're grown in the lab in the millions and millions of cells that are then given back to the patient. And the hope is you not only have you developed these cells that are cancer specific, but these are T cells from that individual patient that's very specific to that patient, going to that patient's specific cancer. It's really kind of amazing if you think about it, and if you think about the ability to do this and some of the advantages that we've seen, particularly in the hematologic or blood type malignancies, nothing short of amazing. Let me give you a quick example of a TIL product that should be coming to us from the market called lifileucel. This was actually the same kind of concept that I described when we were making T cells. You take out the individual patient's melanoma, right? So lifileucel will be approved for the treatment of melanoma, right? You take out the patient's melanoma, extract out the T cells, grow them big time in the lab, and then give them back to the patient. So why was this study done? Why were we looking at this kind of approach? Because it's very elaborate. It's, as you can imagine, very time consuming, if you will. You're subjecting the patient to a biopsy. The reality is, even though we've made great strides in the treatment of melanoma, we have a long way to go. And for those patients that are no longer responding to standard treatment, if they're no longer responding to immunotherapy, if they're not candidates for targeted therapy or another form of therapy, we need other options to try to get their cancer under control. So that's why this whole idea of adoptive cell therapy or developing these tumor infiltrating lymphocytes came about. Lifileucel is a product that has been developed in a process that's been developed such that it can go after an individual patient's specific melanoma. What is the study that was done to prove the benefit? It was a relatively earlier, it was an earlier phase study. Product was made just like we've described. Patients also have to receive a lymphodepletion regimen before they get these cells. Let me try to explain. Before you give the patient the cells, their own lymphocytes that are traveling through, their absolute numbers need to be decreased. So you give them this lymphodepletion regimen, then give them these cells back, and you're looking for an anti-tumor response. So in this particular study, believe it or not, this is the study that really caused the big splash for melanoma. 66 patients were treated. And the important part to remember is these are treatments, these are patients that had had multiple treatments, and every one of those treatments that they had failed the patient. So they're looking for something different, harvest their tumor, make these tumor-specific cells. What was remarkable about it is this is a population that typically won't respond to anything at this point, and yet 1 out of 3, a little bit over, 36% actually had responses. 2 had their tumors go away completely. 22 of the 66 had their tumors partially respond. So if you just even look at that alone, that's amazing in this particular population. 80% of the patients had the tumor growth either stop or go into some type of remission. So like something we've really never seen before in a group like this. The other important observation of this study is even though these patients were refractory to these treatments, and specifically anti-PD-1 treatments, they still had responses. So bottom line, this particular product demonstrated durable responses, meeting a major unmet need in the metastatic melanoma population when there really are no other options. I want to talk briefly about a trial that is coming to KU. We hope to have this open in February of this year, and it's also from the same company that has produced lifileucel. There's so many different concepts that are coming out harnessing this type of cellular technology to fight cancer. So what if we could do this? What if we could develop an agent like this that was less toxic for the patient? That would be an advantage, right? And we have to remember that sometimes the standard treatments don't work for this patient pool. So one of the things that's important about the interplay in the cancer cell, the melanoma cell with the T cell, is that melanoma cells can have this protein called PD-L1. It can block a protein that's on the T cell. If you could eliminate that whole process, if you could remove that, there would be a definite advantage for that immune cell to fight melanoma cells. So the trial has been designed to remove these PD-1 proteins on the cellular surface of the T cells. And then those T cells that are specific for that patient will be given back to the patient without the PD-1. So that mechanism to block activity goes away. And we believe that it's postulated that the toxicity profile will be better as well. This just gives you a schema of it. The tumor's harvested. Again, it's grown in a lab. Hopefully will be grown in a lab in Philadelphia. Then back to us, given along with a medicine called IL-2, and it's a 1-dose regimen. Again, these are for patients that don't have any other treatment options right now in the metastatic melanoma space. We're really excited about it, along with TIL cell therapy in general. So what's going to be its impact? Still remains to be seen, but we do believe that this is a brand new approach to the treatment of melanoma patients. We're hoping this particular trial will have less toxicity and that same anti-melanoma effect, and it's a one-time treatment. And with that, I will stop. We'll ask for questions when Dr. Hamilton Reeves asks for questions.
Great, thank you, Dr. Doolittle. Really appreciate it. Does Tracy, do we have any questions for Dr. Doolittle?
We do not have any questions at the moment from the chat.
Okay. All right, well, then we will go on to Dr. Al-Rajabi. Dr. Al-Rajabi is an associate professor in the Division of Medical Oncology at the University of Kansas Medical Center. Additionally, he is the GI Oncology Section Director and the GI Oncology Disease Working Group Chair at the University of Kansas Cancer Center. Dr. Al-Rajabi, we appreciate you presenting tonight. Welcome.
Thank you, Dr. Hamilton Reeves. I'm delighted to present immunotherapy in hepatocellular carcinoma. Thank you for the organizers. So these are my disclosures. So liver cancer is a worldwide problem. Over 700,000 cases are diagnosed with liver cancer every year globally, and it's becoming a big financial burden on a lot of countries in Asia and Europe. We also see about 40,000 new cases of liver cancer every year, and the numbers are just increasing. The majority of these cancers are liver cancers are hepatocellular carcinomas, and they originate from the hepatocyte, which is the main type of liver cell. There are other rarer forms of cancer in the liver, like bile duct cancers, which we won't talk about today. But looking at cancer death rates in the United States. So in Europe and in the East, there has been an epidemic of hepatocellular carcinoma because of the prevalence of cirrhosis was pretty high in those countries, and cirrhosis eventually leads to hepatocellular carcinoma. We'll talk some more about that. But if you look at the cancer deaths in the United States, because of prevention and early detection, we're seeing rates going down across many different cancers, except for liver cancers. It's almost tripled since the 1990s here in the United States. These cancers are asymptomatic. When they're early, you don't feel anything. And most of the time, these patients are diagnosed with late stages where they have signs and symptoms that include abdominal pain, weight loss, and even jaundice. The risk factors for HCC are on the rise, and cirrhosis, like we talked about, causes a chronic inflammation in the liver, causing DNA deletions and mutations that eventually makes these cells turn abnormal and grow uncontrollably. Now, in the East, hepatitis C is the most common cause of cirrhosis leading to hepatocellular carcinoma. But in the United States, we have a good portion of our patients as a result of chronic hepatitis C, alcohol, and obesity. Obesity is an epidemic in the United States. We all know that, and it increases rates of several different types of cancers. It causes non-alcoholic fatty liver disease in our population, which leads to cirrhosis, eventually leading to hepatocellular carcinoma. Now, there are rarer forms, of course, with glycogen storage disease. We don't see many of those, but non-alcoholic fatty liver disease is on the rise because hepatitis C is being treated more effectively and early on before it causes liver cirrhosis. But we're going to still see these rates continue to rise. These patients are kind of unique because they're dealing with two competing comorbidities. That means the cirrhosis is trying to cause them harm, and so is the liver cancer. So they take a group effort or multidisciplinary approach. And here at University of Kansas, we have multiple specialists that discuss these patients on a weekly basis. Every patient usually goes under discussion, and the group really helps determine the best course of action. These patients also have a lot of social needs. Some of these patients have had illicit drug use, or they've had a lot of these patients could also be our vets that have had a lot of social dysfunction and really poor support systems, and they definitely need our help to get through the process. This is a pretty busy slide, but this is kind of how we treat hepatocellular carcinoma. And as you can see, we take in consideration not only the size of the tumor, but we look at the liver function, which is the Child-Pugh score, and the ECOG performance status, which is how active or healthy the patient is. We hope that we catch most of our patients here. Some of the patients that have liver cirrhosis or they have hepatitis C are screened every 6 months, and what we catch some of them with very small amounts of disease, and we perform local ablative therapies or resections, cutting the cancer out. But some of the patients do present with a little bit more advanced disease. They have large tumors or they have multiple tumors. They still have a good liver function and they still have a good functional status. These are patients that we try to think about surgery in some, but most of them end up needing some form of help, some form of liver-directed therapy. And what we tend to do in these patients is try to get them to transplant. We are one of the regional transplant centers in the area. And what we use, these chemoembolizations or ablations, we downstage these tumors to get the patients to transplant. And transplant not only cures the patient of their cancer, but it also gives them a new healthy liver without cirrhosis. So you can see the median overall survival in this group, if we catch them early, is very high. Now, there are some patients that have multifocal disease, more than 3 spots, potentially, major spread or smaller lesions throughout the liver. These are patients that would benefit from local therapies to a point until they stop working. But a lot of the patients I deal with are the advanced patients, patients that have vessels involved where the cancer is growing into the vessel, or the lymph nodes are involved, or even the cancer has spread to other organs like the lung and bone. And right now, the first established line of therapy is a checkpoint inhibitor, just like Dr. Doolittle mentioned. This is a PD-L1 inhibitor with a VEGF inhibitor that stimulate the immune system in attacking the cancer. Second line therapies include small molecule therapies. These are oral drugs called sorafenib and lenvatinib. And we have another slew of other FDA approvals we'll kind of touch base on in the going forward. But you can see the median overall survival in these advanced patients is good. It's better than a lot of cancers, but it's not great. Now, we do have patients that have very advanced disease, very poor function status. Those patients have require best supportive care, and their median overall survival is about 3 months. So these are the liver-directed therapies we're talking about. This is a RFA probe. So we stick it with a needle into the tumor, and then we heat the tumor until it dies. And then it leaves a cavity. So it's a minimally invasive way of killing small tumors. Now, if the tumors are really large, then we use a strategy of going into the blood vessels, feeding the cancer, and embolizing it with chemotherapy-filled beads or radiation beads. These beads could potentially shrink these tumors where we can cut them out or send the patient to transplant. And this is how it looks under the X-ray. You could see the tumor blushing there with the contrast going into the tumor. But as we talked about cirrhosis, it develops in a milieu of inflammation. So everything's inflamed. The liver is a unique organ which has to be tolerant of what you eat, because everything is purified through the liver. And you have this inflammation from the cirrhosis, which makes it an ideal organ to try immunotherapy on. And we also use microwave ablation, liver-directed therapies, radiation that could potentially break apart some of these tumors, exposing them to the immune system. So if we could enhance the immune response, we may get a response. And that's what we saw in the first line therapy of hepatocellular carcinoma. So going back to 2008, we had the CHARP trial that was published. This improved survival with sorafenib by an average of 20 months. Sorry, not 20 months, 2 months. And very, very minimal improvement in survival, but that was the only option we had up until 2018. Then lenvatinib was compared to sorafenib, and it showed non-inferiority. That means it was pretty similar, maybe a little bit better than sorafenib. Then we tried a little bit of immunotherapy. We saw a signal. We saw some shrinkage in some of these tumors, but the overall survival was still not better than sorafenib until 2019, when they first published the data for the atezolizumab, bevacizumab, and we saw a dramatic improvement in survival over sorafenib with the IM-Brave 150 and the checkpoint inhibitors that we talked about. This was a study we had here at KU, and this was actually FDA approved, I think 4 or 5 weeks ago. And this was called the Himalaya study. And it included 2 antibodies that Dr. Doolittle talked about. One is a PD-L1 inhibitor, darvolumab, and then we have a CTLA-4 inhibitor, tremelimumab. And this combination boosted the immune system, improving survival in these patients up to 30.7% at 36 months. There was a response rate of about 24%, which was way better than sorafenib. That was about 9%, I think, or something like that. So that basically added to our armamentarium in the first line therapy for hepatocellular carcinoma, and now this is available to our patients. So that's what we know so far, that immunotherapy looks very promising, but we see about 50 to 70% of patients responding to immunotherapy. There's still about 30% of patients that really don't respond. And then some of these responses are not durable enough. They're 18 months, but they're not, we want to do better. So where are we going with all of this? So this is a clinical trial developed by our own Dr. Saeed. She thought about adding some of the small targeted therapies and immunotherapy because we think these small targeted therapies improve the microenvironment to allow the immune system to attack the cancer more effectively. Initially, this was a dose expansion phase 2 trial where we had durvalumab and cabozantinib. We saw that our patients were doing very well on the Himalaya study. So we added this third arm, and now patients are being randomized to get both of them to see if we could add more to the immunotherapy and see if we can improve responses. Well, that's really good, but we still know that patients still progress even on our three drug combinations. So going back to CAR T and T cell therapy, this is a study that we've opened here at University of Kansas, and we look at hepatocellular carcinomas. They have two unique targets, glypican-3 and alpha-fetoprotein. Glypican-3 is not seen on healthy liver cells. It's seen in 80% of hepatocellular carcinomas. Alpha-fetoprotein is usually a protein seen in embryos, but can be seen in patients that have hepatocellular carcinoma. So this is the Artemis platform is a antibody redirected T cell endogenous modular immune signaling therapy. It's a little bit different than CAR T. It actually has two signals that trigger it. One is alpha-fetoprotein, and then the second is glypican-3. So these are very, very specific to target hepatocellular carcinoma. So just like Dr. Doolittle mentioned, we pherese the blood, so we kind of do dialysis, get the cells that we want. We genetically re-engineer them in California. They're expanded, and then this process takes about 3 weeks, and then they're reinfused into the patient's bloodstream. After we condition the blood, that means give them chemotherapy and lower the bad T cells that are sometimes helping the cancer cells grow. It's a very complicated process, and fortunately, we have great collaborators at the University of Kansas with the cellular therapeutic team. They're amazing to work with. They have great experience in developing these therapies, and they work with us solid tumor specialists to get our patients through. But you can see how many steps this takes, or this process takes. I'd like to finish off with this. This is a schematic of what is being studied in hepatocellular carcinoma. It's a very hot cancer around the world because of how many people succumb to it every year. And you can see all of the yellow targets that we are studying in these cancer cells and all of the green drugs that are targeting liver cancers. And they both target the cell itself and the immune system. So just in conclusion, we've made dramatic strides in the treatment of hepatocellular carcinoma. Now we need to figure out, with the tools that we have right now, what is the sequence that we need to use for therapy? How do we personalize these therapies for our patients? What are the predictive markers that will predict a longer and more durable response? And can we prevent this? We know cirrhosis is the cause. Dr. Weinman and our colleagues here at KU are working on very impressive work on preventing the liver cirrhosis and preventing the development of hepatocellular carcinoma. Hopefully we can prevent this disease in the future. Thank you very much. I will take comments and questions, and here's my email if anyone has any questions after the presentation.
Great, thank you, Dr. Al-Rajabi. That was really interesting and important work. Tracy, do we have any questions for Dr. Al-Rajabi?
No questions at this time.
Okay, well then we will go on to our third speaker then. Our final program speaker is Dr. Neupane. Dr. Neupane is a professor at the University of Kansas Medical Center in the Division of Medical Oncology. He is the director of the Hematology Oncology Fellowship Program at KU Med, where he also serves as the director of Head and Neck Medical Oncology. Dr. Neupane, welcome. Thank you so much for sharing your work with us. Oh, you are muted, Dr. Neupane.
I'm sorry, thank you. Thank you for introduction. It's really great pleasure to be here and discuss what's going on in head and neck cancer. So a little bit of clarification for some of you what includes in head and neck cancer. Generally, it's loosely defined, unlike melanoma or liver cancer. This is anything that's below brain and above the clavicles or collarbone, anything that comes in that geographic area, we call head and neck cancers. There are so many different varieties of head and cancers can happen in that particular part of our body. Melanoma can happen, but if it's melanoma, I'll send that patient to Dr. Doolittle. Majority of cancers in this area in our body is a squamous cell carcinoma. Squamous cell that can happen from our oral cavity, tongue, throat, down to larynx and all other surrounding areas. As Dr. Al-Rajabi mentioned, what causes this? So well-known cause for these cancers is smoking and alcohol. Last 10, 15 years or 20 years, we've seen a relatively rapid rise of squamous head and neck cancers, particularly in our throat, that's caused by human papillomavirus. So that's the third risk factor. Human papillomavirus is sexually transmitted viral infection that can lead to cancer, and some individuals who have that infection. And if we look at worldwide head and neck cancers, particularly South Asia, Southeast Asia, and a variety of other places, there are chewing habits like tobacco or a variety of other things they chew, and there is much larger burden of cancer of tongue and oral cavity in that part of the world. Challenges in treating those, biologically, they may be different. They're not homogeneous disease based on what causes them. Primarily, we try to remove them surgically or do radiation therapy to cure them. Some of them require surgery, chemo, and radiation therapy, or some of them we treat with radiation and chemotherapy together. But it's still quite often, a lot of patients, the cancer comes back, and that's a life-limiting disease when you have recurrent cancer, head and neck cancer. So we try to develop more treatment and do clinical trials. So why do clinical trials? One of the goals is to develop new treatment for tomorrow. Second is clinical trials bring new treatment for our patients in the region that could be better than the standard of care when you have no other good treatment options, or better than the standard of care from existing treatment, or bring treatment when there is no other option. Clinical trial, either the treatment patient can get in, everything else is exhausted. So a variety of different benefits of having these clinical trials. So talking about how do we build clinical trials? If you look at this publication here, this was 2019 publication. I circled my name on the trial because I just, it's a University of Kansas was a major contributor in this trial that was published in 2019 in the journal Lancet. That trial showed the experimental treatment with one of the immunotherapy molecule was better than the standard of care at that time. On the left and then right, that's further follow-up, longer follow-up published this year in Journal of Clinical Oncology. That benefit holds true even if we keep following those patients for the longer period of time. So with those data, this particular new treatment, immunotherapy with pembrolizumab by itself or pembrolizumab with chemotherapy, was approved as a standard of care June 2019 by FDA. Now this is a standard of care, which was not back in 2015. So Cell therapy is other immune therapy. Dr. Doolittle explained quite a lot of this about TIL and CAR-T and different kind of therapy. Generally, the immune response is a major determinant of influencing the survival in cancer. We learned that. We've seen pembrolizumab and other variety of drugs, durvalumab, Dr. Al-Rajabi just talked about, showed increasing benefit compared to standard of care. So immune system is really determinant. If we can exploit our immune system and push them to the direction of attacking these cancer cells. The recent research in immuno-oncology and cancer biomarkers has underlined the strength, the significance of the tumor infiltrating lymphocytes, that's called TIL, as promising prognostic indicator. If we have TIL-rich tumor, that generally does better than if there is no tumor infiltrating lymphocyte. That's because the TIL or the tumor infiltrating lymphocytes are attacking or trying to attack any tumor cells. And that is true for head and neck squamous cell carcinoma as well. So TIL, I would like to just highlight that the TIL trial, one of the trial we had here called LN-145, which is closed, and there's further reporting is awaited for this trial. And that has been, if the results stay the way we thought would stay, then we'll bring back for the larger trial. This was a phase 1 trial. LN-145, we determined it was safe with a combination of pembrolizumab in patients with metastatic head and neck squamous cell cancer. LN-145 plus pembrolizumab shows early signs of improved efficacy, particularly when compared with the prior reported benefit of pembrolizumab alone, which is the trial that I showed you earlier, which is created pembrolizumab as a standard treatment. Now we're adding TIL to pembrolizumab. That appears better in very early data. So hopefully we'll have this trial, which is not available at this time, but in future in KU again as a larger scale trial. How TIL is prepared, Dr. Doolittle again explained this in great detail. We remove tumor, we have lymphocyte infiltrating that tumor mass. That's fresh tumor is sent to the lab, then we shake it out, so lymphocytes, and select out T lymphocytes out of those, and we grow in the laboratory. After we grow in billions of cells, so we bring it back. Those are frozen. The frozen cells are we re-thawed and infused back to the patient and clinic. So here is another trial, which is not a TIL trial. It's called, it was a phase 2 pilot study, ADP-A2M2 in combination with pembrolizumab in subjects with recurrent metastatic head and neck cancers. So this product is not truly a CAR T cell, but it's a re-engineered T cell receptor targeting very specific antigen in the tumor cells to kill those cells. Those have this particular antigen. The antigen is called MAZE-A4 antigen, and the product of T cells to attack that antigen was called ADP-A2M4. So we had this trial open. We participated on this. Again, this was a phase 1 trial. That means we were just looking for some safety signals and as well as early indication of benefit on patients who are treated with pembrolizumab. And this is a re-engineered T cell receptor. So the trial design with this was patients undergo leukapheresis. That means we removed the peripheral blood lymphocytes. Those T cells from that leukapheresis is collected, and those are infected with viral vector called lentiviral vector expressing high affinity MAZE-A4 specific T cell receptor. And then they are further expanded in the lab. Patients who were started on pembrolizumab single agent monotherapy for 3 cycles. And the disease was evaluated on week 7. If patients have no response to the pembrolizumab, which is the immunotherapy, that's current standard of care, then we go to part B, that is, we bring those cells, patients who bring those cells and infuse into those patients who did not respond and continue with the pembrolizumab with that. Patients who respond to pembrolizumab after 3 cycles will continue pembrolizumab because patients are responding and there's no reason to add something else in there. The sales journey is, again, it's a long path there from removing to taking those to manufacturing facilities, washing, a lot of laboratory process there, and ultimately back to patients. So I don't want to go through the details, but basically we take cells out, take it to the lab, and then expand it and bring it back and infuse. So no results available yet, and multiple sites participated. And here on the bottom level, we see University of Kansas Medical Center. That's one of the sites participating, one of the handful sites for this trial. We're waiting for the result, and if the results show good signals that this idea might work, then we will expand the trial and will be available again for a broader number of patients. Then we have a different kind of head and neck cancer here, this particular type head and neck cancer. And this trial is particularly human papillomavirus directed cancers. It's called SQZ, peripheral blood mononuclear cells for HPV, so HPV mediated disease. The HPV, SQZ PMBC HPV consists of the autologous peripheral blood mononuclear cells. So that means we remove those from patients, just like earlier we mentioned leukapheresis. We remove those cells, presenting immunogenic epitome of E6 and E7 proteins. Those E6 and E7 proteins are seen in patients who have cancers related to human papillomavirus 16. So that's why we're looking at this very specific type cancer that has E6 and E7 proteins in those tumor cells. And with those mononuclear cells contents of T cells, monocytes, natural killer cells, and B cells. There's a variety of different cells seen in those mononuclear cells we remove from patients. Those are in the phase 1. Results showed that this particular product was safe. It showed some clinical benefit by itself without anything else. These patients who previously treated heavily with multiple lines of treatment had no other treatment options left, but it seems to stabilize disease. And a few patients did have some response. There was no dramatic complete response or complete clearance of cancer, but there was some signal that some response. So the further study in combination with anti-PD-1, that is the same medicine or similar medicine I mentioned earlier, pembrolizumab therapy, is ongoing at this point. We're hoping to see good results in combination with this combination, and then further expand the trial for larger population. As any other cancer trial, this trial's at this point for very small, limited number of patients to make sure that it is safe and we're not hurting anyone, and also there is a good, meaningful or promising result with the early test, so that we can expand that for larger population and compare with the standard of care. So those are the cell therapy trials that we participated and hope to reopen it. I don't have any trial that is actively open for cell therapy trial in head and neck cancer here at the University of Kansas Cancer Center this time. But I do want to highlight that we continue to, just because we don't have a cell therapy trial, we're not sitting here waiting for them. We have this trial that is going to be open later this month. It is first-line treatment after we see a recurrent disease when the patient is not cured with radiation, chemotherapy, or surgery and has metastasis. This trial is randomized, double-blind, multi-center phase 2 study. So this is a double-blinded where we are treating physicians and the patients don't know which group they're randomized to. But the randomized arm is called retifanlimab, which is the anti-PD-1, similar like pembrolizumab, in combination with INCAZN02385, which is anti-LAG3, which has shown a really good benefit in melanoma studies. And other is called anti-TIM, this other long name there, INCA02390, anti-TIM. Anti-TIM and anti-LAG both are part of the immune system that inhibit our immune system to fight against cancer, just like PD-1 has inhibitory effect in our immune system to fight cancer. So in combination with these two, anti-LAG3 and anti-TIM, anti-PD-1 retifanlimab, we hope to have better result in a first-line treatment. So this trial is being activated later this month and will be ready to take patients early next month. So TIM and LAG3, and there is another one called TIGIT. Why do we add this to PD-1s? CTLA-4 is another one Dr. Al-Rajabi showed there, has more side effects, still is a very good immune checkpoint inhibitor, has shown benefit in a variety of things, including melanoma and hepatocellular carcinoma. Anti-PD-1 is the other one we talked about earlier, which is current standard treatment for the head and neck squamous cell carcinoma. And now we're adding this LAG3, TIM, and TIGIT. They appear to be quite safe, in fact, much safer than the other ones. And we hope to have combination together and still be safe and more effective in treating these diseases. This is another trial that is going to be open again early next month, which is phase 2 open label multi-center study. The same one of the compound in combination with immunotherapy and anti-PD-1 therapy in participants with recurrent or metastatic head and neck squamous cell carcinoma. So this trial is for the patients who have gone through the pembrolizumab treatment previously, and then that didn't work and cancer continues to grow. We can enroll in this trial and hope to have this combination be more effective or reinvigorate the immune system to fight the cancer and provide benefit. These two trials will be ready by early next month. So these are the trials we have currently. So thank you. And that's all I have in terms of presentation. Happy to take any questions.
Hey, thank you so much, Dr. Neupane. Tracy, do we have any questions specific for Dr. Neupane?
We do. One came in. Is there a difference between infecting a cell and infusing the cell?
So there are a variety of techniques, and I couldn't give you really clear answers that there an infusion and infection is different, but I don't have that details of the laboratory techniques to explain that.
I think it's fair to say, though, that when we're talking about any kind of cellular therapy, once the cell has been engineered differently, as Dr. Neupane said, it's frozen. They send the cells back to our site or whatever site's doing the treatment, thaw the cells, and they infuse them just like you do a blood transfusion. It goes right back into the bloodstream. So it's like, that was my biggest disappointment when I started bone marrow transplanting as a fellow. It's like, are you kidding me? This transplant is nothing other than a blood transfusion, giving bone marrow back through the vein. So and then this other, because the terminology gets confusing. I can tell by the question. The other piece of it is, sometimes we actually use a viral infection to insert the gene to change the cell, and that may be more than you want to hear right now. But in order to get the gene placed where you want it to, there are various mechanisms we use. So maybe that's where the some of the confusion and the terminology came from. It is confusing. I mean, I find this in the clinic trying to talk with patients. How do I get this to a point where it makes sense? And they've done their reading and they've done their research. And it's really up to us to find the right words to make it clear to the patient. So it's a complex process. And frankly, if I'm talking about TIL therapy, I'm happy if they get 30% of it the first time we talk, because it's so complicated, and it's going to take more than one session before all these terms and everything start coming together, I believe.
Yeah, thank you, Dr. Doolittle. Tracy, I thought I saw some other questions in the chat. Would you pose some of those questions to the group?
Sure. Actually, I do have a question for Dr. Doolittle. What are the side effects / adverse events associated with TIL cell therapy and CAR T cell therapies?
Okay. So we have a lot more in the literature right now about CAR T cell therapies and the approaches. And, you know, from start to finish, you're talking about a months-long process. From the time you get your CAR T infusion, it's typically 3 or 4 months before the patient gets back to kind of their normal state. But it's those first few days and weeks that are the most challenging. And with CAR T, I think the first challenge is cytokine release syndrome, CRS. And that's just a problem that happens when the T cells are infused. They dump a lot of cytokines or proteins, if you will, into the bloodstream, and it can cause fever, it can cause chills, it can cause low blood pressure. And it can be really a frightening thing for patients. And yet, with the right team, they're used to dealing with this side effect. You can manage it with steroids, but you don't want to. You really want to support the patient through that. And as a very last resort, you would give the patient steroids to try to reverse it, because if you give steroids, you're going to negate the benefit of having had the cells. So it is a very complex process and procedure, and you really need a team of physicians that's what they do. That's what they specialize in. That's what they do. And there's any number of side effects that can occur over time in that population. The acute things, the fever, the chills, nausea, vomiting, that type of thing. But you can have multiple complications that occur. Fortunately, the majority of those that are possible do not happen. TIL cell world, I'm not saying a TIL cell procedure is an easy one, but I think the acute challenges with giving TIL cells back to the patient aren't documented as challenging as the CAR T. Remember, the changes that we're in the lifileucel example, that's the patient's own cell that has been multiplied in the millions. So you're basically giving them their own cells back, so to speak. The challenge in the TIL world is you have to harvest the tumor. You're putting a patient through the procedure. We have to pre-treat them with 4 days of chemotherapy. Remember, we talked about bringing the patient's internal lymphocyte count down. So you've got 4 days of 2 drugs that are chemotherapy drugs and the side effects associated with that. When you give the cells back, we don't have the same kind of challenge as you see with CAR T, but we do have to watch for a reaction. And then patients get a drug called IL-2 after that for TIL cell therapy. And IL-2 has a lot of side effects such that the patient has to be in the hospital. And virtually every organ system can be affected by IL-2. Fortunately, we have very good protocols to follow to help us manage the side effects that you get with that drug. That's more than you wanted, whoever asked that. Mary Ellen, sorry.
Thank you, Dr. Doolittle. Tracy, are there some other questions in the chat?
Yes, we do have a question for all of our panelists. Do you anticipate that immunotherapy for solid tumor approval will first be in melanoma, GI, and head and neck? Are these the furthest along in terms of research trials?
Would
I can-
somebody? Yeah,
I
thank
can
you.
answer a little bit. Yeah, so TILs and HCCs really in the beginning stages. It's definitely become a very prominent technology at recent immunotherapy meetings. So I think it's definitely the wave of the future. There have been other products that have been tested over time, and some of them have worked, some of them haven't. But I think melanoma definitely has is going to be one of the first ones. We know there's a product that's being developed, but I think GI malignancies are still lagging behind. We're still kind of in the infancy phase from the GI standpoint.
Yeah,
Go ahead, Prakash. I'm sorry.
sorry. I agree with Dr. Al-Rajabi that it'll eventually come to all disease areas, and melanoma and cell therapy or immunotherapy in general, melanoma is much ahead of other solid tumors. And for a reason that tumor biology is different. And in head and neck squamous cancers, and there's a relatively early trials, TIL or the T cell receptor or potential CAR T type therapy. And all of this therapy, you saw that challenge is you have patients on cells, you send them to lab, you cook them in the lab, bring it back and infuse, and there's a lot of lag time there, waiting time. And hope is that eventually we have a product that's going to hopefully work in everyone. Cell therapy, we put on the shelf, take it out, just like any other drugs we do, and infuse in the patient. That would be the nice, and likely that's where the future will move gradually.
Right. And I would jump in just quickly and make sure that we're clear with the group that we're talking about the solid tumor arena right now. So the non-blood related tumors, because CAR T is the standard for some of the hematologic malignancies. But as we talk about the solid tumors, in our cases today, melanoma, GI, and head and neck, melanoma is probably further along. The interplay between the immune response and melanoma has been known for quite some time and is greater than what we see in the GI and the head and neck arena. But I am very optimistic that as we harness this technology and develop new cellular therapies that have targets for particular solid tumors. Like, I love the study that Dr. Al-Rajabi was talking about, where it's alpha-fetoprotein and going after that very specific protein that's specific for HCC. That just makes sense. So I think this is going to, I think it is the wave of the future. As has been the case my whole career, the blood-related cancers do better and continue to do better with newer technologies, and that's the case here too. But I'm really optimistic about this approach for solid tumors as well.
Thanks, Dr. Doolittle. Tracy, do we have any other questions in the chat?
Looks like we have one more question for Dr. Al-Rajabi, and this is in relation to your slide about the connection between liver cancer and oral contraceptives. Could you address this, particularly the risk and what you see as the risk for young women who often take these contraceptives for many years?
So the risk is really low. They develop a precancerous lesion called an adenoma, and these adenomas can potentially turn malignant. I would say 90% of these adenomas never turn malignant. They regress after stopping oral contraceptives. HCC is a hormone-sensitive cancer, unlike some other cancers in the body. So people that are taking very high levels of testosterone, bodybuilding, other hormones could potentially increase their risk of hepatocellular carcinoma. Usually normal, taking contraceptives even for a very long time doesn't dramatically increase your risk, but occasionally we see patients that develop adenomas, and as soon as you stop the oral contraceptives, it goes away without, they shrink on their own.
Oh, really interesting. Thank you, Dr. Al-Rajabi. Tracy, any final questions for the panel?
I think that's all the questions we have for today.
Okay, great. Do I go ahead and hand off back to you, Tracy, then? I think, yeah.
Yes, certainly. I will.
Okay.
I'm happy to close this session. I just want to take the time to thank again Dr. Doolittle, Dr. Al-Rajabi, and Dr. Neupane, as well as Dr. Hamilton Reeves for sharing with us all of this fantastic information today. Just want to remind you, if you're wanting CEs, we did put that information in the chat. We will also be sending that out again via email. So you have all of that information. We also have a session evaluation that we would appreciate you filling out. It will just take a few minutes. So we will be placing that in the chat as well. If you could go on to that link and complete that survey, we would appreciate it. And with that, we'll say thank you and close today, and appreciate everybody joining us for this session. It was very informative.
Thank you.
Thank you.
Thank you.
Thanks,
Thank you,
everyone.
everybody.
Great job.
Thank you. Good night.